Thank you. So welcome all. There was some delay in the setting of YouTube. So we are live on YouTube and we are recording this. So welcome everyone for the 2026 Shaft Expert Symposium series. We are starting the series by focusing on lifestyle diseases, primarily on obesity, and the current trend in using the GLP-1 drugs. We thought, okay, it will be good to start with this to give some insights to get experts who have been using these medicines for the patients. And we have one more person, Dr. Araman, and he's been using this drug on himself. He's a good friend, and we have the main speaker, Dr. Deepak Chaturvedi. He'll be talking about the basics. He'll be talking about his experience by using the drugs on his patients, and I'll be covering about basics of GLP-1 drugs and how the drug has been evolved. So let me share my slide. Please wait. So this program is being supported by the Brahma Samaj committee because we want to share knowledge with everyone to be a part of Vasudeva Kurumbakam. Om Ekmeva Advidiyam Brahmam Sannama Rupa Vivarjitam Rudam Satyam Parabrahmam Ishwaram Lokapalakam. So today's agenda is there, as you told, this is the agenda. The question what many faces is that they take the obesity issue very simply, that when the input is more than output, that means your energy expenditure is more than the energy, your energy expenditure is less than the energy being consumed. This is always not true because we have seen patients, we have seen persons who are quite, a little bit well lean, but they eat more. But we have seen patients who are actually obese who eat very less. So we have seen the paradox. So this theory is not wholly true for everyone. So what we need to understand here is obesity is not just being fat. It is a chronic, progressive, relapsing disorder which has a dysfunctional adipose tissue. The adipose tissue is so resistant that it is not going back to its native state of being native state. And this can lead to excessive accumulation of fat and more specifically in abnormal deposit, specifically in the wrong place where we don't want the fat over there. This is what I want people to understand. Beyond the concept of overeating, there's something called as the inflammatory cascade. Once you see from this, there is a chronic low-grade inflammation, which is going to send lipotoxic signal. There is mTOR pathway suppression in the bone marrow cells. So this finally leads to the adipokine dysfunction. This leads to insulin resistance, and again, this can lead to the abnormal proliferation of the fat cells, both hyperplasia and hypertrophy over there. Few facts. Weight is not a good measure of obesity. We always see for the weight. Weight divided by height, which is more than 0.5, it gives a simple measure, but it is a sex neutral. The above ratio, when compared with the BMI more than 23, gives a clear diagnosis of what is the grade of obesity they are. When the BMI is more than 28, the waist ratio, the weight height ratio less than 0.5, here we need to measure the fat distribution. The best way to measure fat at least DEXA scan or body composition, but 90% times we don't need that. We can measure in other ways also. When is the indication of the bariatric surgery? When the BMI is more than 40 or when the BMI is more than 35 with concomitant comorbidities. In a simple way, you can say that during the management of obesity, a minimum of, a simple to start with, a minimum of 5% reduction on the body fat is when the benefit starts. More the lowering, more the benefit. So we need a hypercaloric diet which the patient need to be sustained, not like binge not eating and binge eating that. Of course, the lifestyle and the proper diet planning is key. Physical activity minimum 60 minutes per week. And we have multiple tools such as the calorie intake, the fat distribution. We all know that. Now coming to the pharmaceuticals. All the drugs which have been developed for managing obesity, they are all acting at the central pathway. Everything was targeting the central system. Mainly, they were trying to reduce the appetite, either through a serotonin system or monoamine reuptake or cannabinoid receptors, any sympathetic stimulants, and other drugs, making the off-target effects very likely. Because once you go there, once you hit the central pathway, it is going to hit in a multiple way. So many historic drug withdrawal we have seen that occurring up to post-market surveil. Everything, every drug, these drugs, many times they clear the clinical trial. But when it comes to the actual real scenario, that is phase 4, that is called as post-marketing surveillance, here it reveals a harm which has not been evident in the pre-approval trials. So this is the few drugs like fenfluramine, dexfenfluramine, lorcaserin. These have been known to cause some heart valve damages. Sibutramine increases risk of MI stroke. Most commonly used rimonabant. It can cause psychiatric illness, increase suicidal thoughts. Amphetamines, of course, we don't use it because it has high dependence of abuse. And phenylprophyllamine, it it had a high hemorrhagic stroke risk. So these all drugs are banned now. Now what we have? These drugs are off-label use for obesity. Of course, we know the metformin, uh, which is being approved for insulin resistance cases also, even in PCOS, they give metformin. So this drug is given very specifically when there is an insulin resistance issue. Then comes the SGLT2 inhibitor, that is all the glyphosins. These drugs can cause a modest weight loss, and the drug exenatide, uh, though less commonly used. People use even bupropion and zonisamide, like afloxetine, and pramlintide. These drugs, of course, we use only metformin and SGLT2, but not very specific, only for diabetes. When there is obesity for obesity, when there is diabetes and obesity, we tend to use metformin and SGLT2 inhibitors. Now, coming to the GLP-1, very focusing in India, the drug approved is semaglutide. The dose is 2.4 mg for obesity. We also have oral semaglutide. This is a non-peptide drug. I'll be telling you what's peptide drug and the non-peptide drug. It is approved for diabetes. In India, it is not approved for obesity yet. The other drugs are liraglutide, dulaglutide, exenatide, and tirzepatide. Tirzepatide is called as Mounjaro, and semaglutide is the brand name is Ozempic. Now, how does these drugs act? All these GLP-1 analogs, they mimic the GLP and they go and bind to the receptor. So they are also called as GLP-1 receptor agonist. We have two types. One is called as the peptide as well as non-peptide. Non-peptide, because when there is peptide, it goes and gets degraded with the gastric peptidase enzyme. So these drugs cannot be given orally. So then came the era of non-peptide drugs. One is oral semaglutide. Oral semaglutide is kind of a peptide drug, but it has been given a separate formulation. It's called as SNAC. The other drugs, the oral component, which I will be showing hopefully in the next slide. These drugs, here it is. Danuglipron, oflicipron. This is danuglipron has been discontinued. The currently available non-peptide oral GLP-1, the drug is orforglipron. The other peptide oral drug is semaglutide. Of course, we are more concerned about the side effects. As you can see from this table, even though we consider about the thing called NaION, the instances are rare, but again, many cardiovascular risks are coming up. So what does it show? This drug has become a celebrity trend now. People don't understand the risk out there. So always we have to weigh the risk versus benefit. For example, when the patient, in case of the fertility management which we deal with, the patient is having very high BMI, the patient is going for any fertility treatments, and so patient will be given the instruction that to lose weight. So how can they lose weight immediately? So patient were given the option of putting them on these drugs. These drugs can itself have some other side effects, but along with physical activity, these drugs have shown to cause good weight loss, which can have a positive impact on the fertility outcome. Not the drug, but the weight loss, the parameters. So these are the drugs, because I don't want to explain all these things. You'll be knowing that. And these many side effects are there. So people have to be very careful before self-prescription and going to the market and saying that I want this to do this, do that. And of course, for patient also while taking the drugs, Please be very mindful of these things. So thank you. And the next session, Dr. Deepak Chaturvedi will be talking about his own personal experiences with the semaglutide drug and the Ozempic and the Mounjaro. Please wait. Hello, sir. Good evening, sir.
Yeah, good evening, Dr. Natesh. How are you doing?
I'm good. I'm good. So thanks for joining amidst your schedule.
No,
Let me have the
no,
pleasure of
it's a
introducing you.
pleasure.
Yeah.
It's a pleasure. It's a pleasure, and
Yes.
I could see your last few minutes of your session, and that was really very enlightening. Thank you so very much.
Thank you so
And
much.
sorry,
Let,
I'm
let,
in the I'm in the
let me
clinic, and
just
this is
introduce you for a minute.
yeah, sure, please, please, please.
Because, yeah. Instead of telling myself, I want to show the content. So because uh, we met during conference and I have been impressed with your the presentation. I know you are a good speaker. So I want to introduce you to our people here so they get the best benefit out of this lecture. Just a minute. So Dr. Deepika Chaturvedi is a physician who is expert in the field of diabetes, thyroid, obesity, and he's a age man consultant because he's having a research called as Amar, where he's focused on research on how to use hormone management for anti-aging, and also he's having an obesity and weight loss consultant clinic. So people know about him. He's a very good speaker, orator, like in my multiple conferences we met, and he's having his own clinic from Mumbai, Army Multispecialty Clinic, and he's a life member of IMA, and he's having his the first clinic called as Amia Clinic, then came the Anvi Multispecialty Clinic, and he's also a co-founder of the World Age Management Medicine Network, and multiple accolades are there. So these are the key area of expertise, holistic wellness, and the internal medicine over there. Fine, sir. Welcome, welcome.
Yeah,
So please share.
thank you
I don't
so
want to waste
much.
more time. Yes, thank you, sir. Yes.
Thank you so much, Dr. Natesh. I hope I'm audible. Am I audible and clear?
Very precise, sir.
Perfect, perfect. So the topic given to me by Dr. Natesh is about do's and don'ts of uh, these newer medication like Monjaro, Ozempic. I'm directly taking the brand names because they are now known as their own products, and people know them by the brands more than their molecule, like any other medicine. So Ozempic, the semaglutide, and Monjaro, the terzeptide. So I'll just go back to a short, quick history about obesity per se. How when I started the practice somewhere in 2008, a bit before that, and at that point of time, what the scenario was and what the scenario now. At that time. obesity was or weight gain was taken more as a lifestyle disorder or something secondary to only the lifestyle. But at that time also we were, we the doctors were very clear that obesity is not merely a lifestyle disorder. And I used to use that phrase at even at that point of time, and I'm sure Dr. Natesh would agree with me, and the other eminent speakers on this dais will also agree with me that we were we at that point of time in 2008 and even before that, we used to say that obesity is a disease in itself, and obesity is actually a chronic remitting relapsing disease. When I say remitting relapsing disease, means somebody tries to lose weight, he loses weight, but again it comes back because weight is a dynamic process. And we have always been struggling, to make that input from the medical side on how to manage the weight or the obesity or being overweight in the population. Whatever the medications which were available at that point of time, I'm talking about 20 years back or so, were more either the appetite suppression or we were using the medicines off labelly to give, the medical intervention of the weight management, which even Dr. Natesh has mentioned the medications in his presentation. And then came the medications like liraglutide, means the Victoza. I'm using the brand name very freely, and but I'm not endorsing anything over here. Though I'm just it's a disclaimer from my side, which was not approved for the weight management in non-diabetic people, but gave us a very good hope and very good results in the diabetic overweight people. And with the liraglutide, before that, exenatide was there, then liraglutide, and then things were just moving around this one molecule of liraglutide, but restricted to the diabetic obese people. We as doctors have used the molecule very judiciously under supervision, even for the non-diabetic overweight and obese people with fairly good results. And then in 2020, we all know, the medical world got this molecule, the semaglutide. Ozempic came in, but then the COVID era was there, 2020, 2021. So not very widely used globally, though in the US they were used. And then came the 2020, the terzeptide, the Monjaro. And that's how the whole story started. With the Ozempic and Monjaro, semaglutide and terzeptide, there was a new hope in the people to lose weight by using these medications. Are not very difficult to use because once a week injection, the people were very comfortable taking it, though not very easily available to the general public, the general population. It took a lot of time from 2020. It took almost Ozempic in India launched now, somewhere around 1 month back, officially launched in India about 1 month back, but was available otherwise in the gray without the proper channel. And Monjaro took almost about 3 years. 2022 it was launched, and then it came launched in India. I'm just talking about the India. So the 2022 Monjaro came, and but it launched in India somewhere in the first quarter of this year. So it really took a lot of time for these medicines to come to India officially. But before that itself, before these medicines came to India, these medicines really made a lot of waves in the Indian public, in the Indian media, and most importantly, the social media. Celebrities were using it. A lot of celebrities were even endorsing it. There were all the articles all around the country. Social media was flooded with it. Instagram reels were being made. YouTube was flooded with it. Like a miracle has come, and people were just using them and buying them. First is buying them from whatever sources they could with the pricing maybe 5 times or 10 times of the real price. but they were ready to take all that pinch of salt and do for their weight management. And indeed, people were getting the results. And finally, then the good news, and the people and these medicines got launched in India. Now I come to the so this is the whole thing which what happened between the launch of these medicines in the Western world, and then took about 5 and 3 years to come to our country, India. Now these medicines are available in India, and the doctors are writing it. But with increasing prescriptions, increasing use of the medication, making the medication available, making the people more aware. I will not say knowledgeable, but aware about the medication. Also comes the responsibility of guiding the people on the do's and don'ts of these medication. And here comes my topic. So, so I will just put them in a single group, like the weight loss, or I will just use it like I will use this layman phrase of weight loss injections, Ozempic and Monjaro, and I'm keeping that diabetes part out of it right now at this current point of time to make it a bit easier. Okay. Now, for these two, for these medications, one thing, what is the most important thing as doctors? Now, there are two things. There are three, actually, there are three parties. Party number one is the individual, the patient, or any person who is using these injections. Party number two is the doctor who is prescribing it. The party number three is the retailer, the pharmacy who is dispensing this medication. So let's understand the responsibilities and do's and don'ts of all the three parties. So first, I will come to the responsibility of the doctor. So when a doctor is prescribing Ozempic or Monjaro, what a doctor should ideally see in the patient. So question number one, the doctor has to ask to himself or herself, is the patient eligible for these medication like any other medicines? Is it justified to write or to prescribe Monjaro and Ozempic to a particular patient? The answer is very clear, and I'm again restricting myself to non-diabetic, obese people or overweight people. So if a patient is overweight, let's keep it very simple. If the patient is overweight, patient is eligible for the prescription of Ozempic or Monjaro. Then comes the question, what doctor has to ask whether the patient is fit to take these injection. Are there any contraindication in that patient, whether to whether to really give these prescribe these injections like Monjaro or Ozempic? And for that, the doctor has to perform these clinical evaluation and the lab evaluation. And in that, the most important comes are the serum amylase and lipase. So the pancreatic enzymes is something what doctor has to every doctor has to see before prescribing Monjaro or Ozempic. And if the amylase lipase are high, then that patient at that particular point of time is not fit for Ozempic or Monjaro. Then comes uh, any history of gallstones which is not being treated surgically. Those candidates should also be ideally should not be kept under the basket of the prescription of Monjaro and Ozempic. Then if there is a history of any malignancy, and here I will not restrict to only thyroid malignancy, any malignant history we should be very careful. And in current point of time, I would rather say that we should stay away from prescribing Monjaro and Ozempic, because we don't have much of the data about the safety of these injections in this group of patient, and we have to wait for few more years to see to have those data collated and then have the final inference of that. Other than that, the people who are not motivated enough to follow the dietary restrictions what the doctor tell them, those people should not be given Monjaro and Ozempic. And in that, very important is the patient should not be consuming alcohol during or even after the regime of Monjaro and Ozempic is over. When this question comes, and a lot of people ask whether we can take the alcohol after we reach to our target weight loss or something, then the answer should be, once you have stopped alcohol, it is better to stop alcohol forever. Why to reintroduce it back? And then why the people should be away from alcohol while being on while being on these injection Monjaro and Ozempic? The answer is very clear. Very clear. It's not only about Mounjaro and Ozempic, it's about any modality of weight management anybody is doing. At that particular point of time, we have to understand that there is a lot of load during this whole process of weight management on the pancreas itself and on liver and on kidneys. And then at that point of time, we don't want to add up any extra burden or any extra insult to these organs. And for that, it is very, very important then the patient that the doctor tells the patient to stay away from any sort of addictions, including smoking and alcohol. You can always ask your patient to choose between the two, either these injections or alcohol. And actually, now Monjaro and Ozempic, these drugs are going to be tested for even making people to withdraw alcohol. So they will very soon get the approval for assistance in alcohol or smoking or smoking cessation, and that would be something very good. So these are the things, and then what further needs to be done by the doctor is the ultrasound of the abdomen pelvis to see the status of the pancreas. Is the pancreas inflamed, or is too much of fatty infiltration in the pancreas, or and the gallbladder? If there is a gallstone or if there is any sludge in the gallbladder, we should be very careful while prescribing these medication. And out of like I have witnessed one patient who had the like who had developed actually the biliary stasis and then a huge gallbladder, gangrenous gallbladder, which had to be removed actually. Then the cholecystectomy had to be done. So we have to be very clear about that before starting these medication, the gallbladder should be hale and hearty, not having any gallstone or any sludge in that. Other than that, we need to do the ultrasound of the thyroid, and because there is a lot of talk about it, the medullary carcinoma of thyroid, family history of medullary carcinoma thyroid. Not many people even know about whether they have any such family history. So we have to be careful and do that. And if there is any nodule in the thyroid which is hypoechoic and which is more than 1 centimeter, it is always better that we should stay away from prescribing these medications till we have clear data and literature about the safety of Ozempic Monjaro in such patients. In any way, any patient who is presenting with hypoechoic nodule in the thyroid gland, which is more than 1 centimeter, we have to evaluate it further for any any malignancy. Otherwise, also. Other than that, because there has been a lot of hue and cry in the population about the retinopathy caused by these medications, which is still have to be proven, which is still have to be proved. But yes, to be on the safer side, it is better to get the eye checkup of the patient done, because in diabetic people, in any way, the annual eye checkups are done, and so we have a document of whether there is a pre-existing retinopathy or not. But in non-diabetic people, usually they don't do their eye checkup very regularly. So better to ask them to get their eye checkup done and to document it. Then the question is whether in retinopathy, whether we should give these medications or not. Answer is not very, very clear. But once there is a retinopathy, I don't see any harm or anything worse going on. If retinopathy is already there, by giving these medications, if we can help the patient otherwise in losing weight. So these are the prerequisites what need to be done. Along with that, if because if there is not too much of test and investigations happening, is not too much of burden to the patient, then we should do a sleep study to rule out the OSA, the obstructive sleep apnea. In any way, every overweight individual should do the sleep study. And if there is sleep apnea, definitely CPAP should be advised along with these medications. And one more, and the good news is that terzepatide, Monjaro, has already been approved to be used in the patients of obstructive sleep apnea. So these are the things what the prescribing doctor need to do, and with the experience and writing more and more prescription, every doctor understands that what better they can do with their own experience to not to do any harm to their patients, and if there is anything happening to either stop that in the beginning or to reverse that complication. The blood work, including your thyroid profile, the HbA1c, serum insulin level, fasting, lipid profile, liver function, kidney function, amylase, lipase, urine protein, very, very important, and if possible, UACR, to be done in the beginning of the before starting the medication, and if possible, to be repeated every 3 months. Ultrasound to be repeated, if possible, every 6 months. So these are the things what to be done while prescribing these medications to any patient. And when the patient asks for how long I have to take these medication, the answer is very clear. For diabetic people, there is no end limit if the patient is tolerating these medications well. But if for a non-diabetic or overweight obese people, once you reach to the target, then definitely we will taper down the medication by the dosing, and then we stop that. Then my experiences with my patients, I'm sure I have done more than 300, more than 300. I don't have the number exactly because I've stopped counting them. I have found a phenomenal result, and I'm using this word phenomenal. Why? Because these are our personal experiences in terms of the weight management of our patients. And even in the patients whom we have stopped the medicine after achieving the target, patients have not, most of the patients have not gained the weight even after 3 to 4 months of stopping the medication. See, please understand that we have been prescribing, and I have no hesitation saying that we have been prescribing the medication even before they were launched, because people were in India, because people were in any way availing these medicines from here or there, and they were misusing the medication. So as doctors, it became our responsibility to supervise them. And with that, with the experience of more than 300 plus patients being on Ozempic or Monjaro, I can say that the complications of, like the way I told, of one patient having the biliary stasis, and we had to remove the gallbladder. There was one episode which has other valid reasons behind that. Otherwise, other than the small acute side effects like gastritis or hyperacidity, constipation, and some patients diarrhea, which are easily manageable by the other medications like any proton pump inhibitor or H2 blocker, or the diarrhea by like something like loperamide, or constipation by fiber or a laxative. Things were easily managed, and people are able to do good and able to manage it. Now for the patients, what patient also, so this is about the doctor side. Now from the patient side, the bigger responsibility is of the patient. Now what is happening? Patient takes a prescription from the doctor, and then patient just never follows back. Like many patients don't follow back with the follow up with the doctor, and they keep on taking the medicines from using the same prescription. And in India there is no validity of the prescription. We write it, but nobody bothers about it. So when you write a prescription to somebody and write, say, example, injection Monjaro. So that prescription is valid for 4 doses, right? Because a pen contains 4 doses. But the patient will keep on going and taking the medicine from here and there, and without any supervision, just take them because they feel that, okay, A is giving us a better deal, B is giving us a better deal. Why I'm going with 5 mg? My weight loss is slowed down. I take 7.5 and all. They do that. They do those mistakes, and they don't do supervision, and they land up in the complications. And the most common complications where they'll end up again is associated with either gallbladder or with the pancreas. And now these complications are piling up because of the unsupervised treatment taken by, or unsupervised medication taken by these people. So the patients have to be very clear that they need to follow with the doctor. They should never take these medicines because the next door is taking the medicine, or somebody in the family is taking the medicine, or share the same medicine with his or her, either the spouse or the sibling or whoever. They should never do that. Proper supervision, proper screening, proper follow up with the doctors is very, very important. Patients don't need to, should not get carried away by the promos which are coming on the social media, or the social media like Instagram reels, or the big advertisements happening here and there, and start these medications by themselves. This is something what patient need to understand. Patients should always follow the dietary recommendation given by their doctor. They should not make their own, those experiments. And very importantly, they should stop following those diet apps when they are on these medication, because these diet apps don't understand the seriousness of these medications. So therefore, the role with the doctor is very, 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 very important. Patient needs to be away from alcohol and smoking or any other recreational drugs if the patient is using. Very important. So these are the things what a patient has to do. Patient has to understand that it is their right and it's the duty of the doctor to discuss these medicines with them, discuss the eligibility of these people with them, discuss the fitness, discuss the contraindication, discuss the dose. This is absolutely understood that these are the right of the patient and the duty of the doctor. But patient also has the responsibility to take care of themselves and follow the guidelines very compliantly, religiously, and I should say use the word fanatically here. I'm using the word fanatically because these medicines, if are being prescribed, should be used fanatically by the patient with all the guidelines given by the doctor. And then comes the third party. The third party is the pharmacist, the medical stores. And somehow this trend is becoming very bad where the medical stores have been given, somewhere, I don't know who gave them the right and that implied, sense of freedom that they can directly approach any patient by a WhatsApp and tell them, hey, there is this weight loss drug and I can give it to you and you should take it. And this is what is happening, at least in the metropolitan cities like Bombay, Delhi, I'm sure, Bangalore, Chennai, everybody, everywhere it is happening. And then people get carried away because they give them so much of gloomy picture and they finally take this. So medical stores today are having primarily, it seems that it is apparent that they are having no accountability. They don't need any prescription. They feel that they don't even need prescription of medicines like Ozempic and Monjaro, which are actually having a warning, that they have to be used. So, so hello. Yeah, sorry. So these medicines to be used under supervision, and they just keep on selling these medicines directly to their own contacts and their own people. And this is somewhere, and they are not even the medical stores at many places don't even have those facility to maintain the cold chain of these medicines. And there it becomes a problem that from dispensing the medicine under a prescription or on a prescription by a registered medical practitioner, medical stores start playing the role of the medical practitioner and start dispensing these medicines to these people for their own vested interest. And that should be strictly taken care by the authorities. And this is something what medical stores have to understand. So what are the do's for the medical stores? So medical store have the responsibility to make these medicines available in their outlet, and then to dispense this and to maintain the cold chain of these medicines, and then to dispense these medicines to their clients, because for them these people are the clients, and for us doctors these people are the patients. So to dispense these medication only and only with the valid prescription, and only the dose should be decided by the doctor and not by the medical store. So these are the small, but very, very important do's and don'ts for the medical store people. So the three parties, here in this whole obesity management, the buy these medication like Ozempic and Monjaro, the patient himself or herself, the doctor, and the medical store or the pharmacist, they have to come in conjunction with each other and respect the boundaries of each other, and do these follow these guidelines. Then I'm very, very sure and very optimistic that these medicines can really do something very great in terms of managing this epidemic of obesity in our, not only in our country but globally. And also when the supervised management is happening, the side effects will be less, because when the side effects start pooling up, then the medicine gets a bad name, and finally the medicines are withdrawn from the market. So we have to use them very, very, very judiciously, very carefully. And yes, it is our duty to discuss these medicines with our patients and prescribe them, whoever are eligible and fit for these medicines. And yes, let's fight with this epidemic of obesity so that we can prevent further complications of obesity, which the world is looking towards. And I think with this, I have tried to explain the do's and don'ts of these injections, like or even the tablet in that way, the Ribelsus, the semaglutide, and the injections like Ozempic, Monjaro, Wegovy, or your peak is there. Now, one more thing I want to add up over here, and then I will be done. Then in next 2 months, maybe by March, the Ozempic will be losing its patent, and many more brands will come in the market. Many more companies are ready. So maybe in next 5 to 6 months, we are expecting a lot of brands, to a lot of players to come. So the cost will also go down. Once the cost goes down, then a lot of people will be taking these medications. So we have to, it is then it becomes the responsibility of the authorities and the doctors and the medical stores to make sure that the people who are taking the patients who are taking these medications are supervised well. This is very, very important. So, with more availability and cost coming down, our responsibility will go up. And then one more good news is that Wegovy 24 milligram oral tablet is already being approved and already is there or launched in the US. So we are expecting that that would be there in India maybe in next maybe 5 to 6 months. So once that oral medication other than Ribelsus is also there in the market, then more and more people will be using these molecules. So these do's and don'ts should be very, very clearly discussed with the doctors, discussed with the patients, discussed with the medical stores. And with this, we can make these medications more favorable to the patients, and the pros and cons will be more towards the pro rather than the con side. And we will be able to, if not win the epidemic of obesity, at least control this epidemic, and maybe more and more molecules coming in, and the people are getting more conscious about their own lifestyles and all. I'm very, very sure and very hopeful that in next 15 to next decade, we will be in a better position in terms of the obesity epidemic. And with this, I would like to conclude my talk, and I hope I'm able to answer the unanswered questions with my talk. If there is any question, please feel free to ask. Dr. Natesh, I am done.
Hi, sir.
Yeah.
So very good insights you have given about how the drug has evolved from the past, from the all the gray market, the actual scenario, and
Yeah.
you actually very well segregated from whom is the drug is coming and what is the role of the pharmacist. So
Yeah.
I'll explain. Uh, we have few questions in the chat box. I'll be asking if
Please.
the audience have to interact. Please unmute and you can ask questions. Of course, the first question you have asked, I mean, you answered already. Can non-diabetic people take the medicine to reduce weight?
Yeah.
Yeah,
Yes.
that is
So
one.
that is approved for the non-diabetic obesity people.
And Dr. Ramaraj is asking, is it necessary to same lipase and amylase after 3 months
Yes.
of initiation of Monjaro?
Yes, we should. We should. And we have seen it is my own. Again, I'm not an authority, but with the use with more than 300 plus, so definitely I have a very strong data of that. Amylase lipase of the patient in 3 months should be done because uh, we know that these medicines can cause the fatty medicines themselves can cause the fatty infiltration of the pancreas, and we have to be careful in that. So better to do amylase lipase because we cannot simply go and keep on doing the ultrasound of the patient. And there is one more thing I want to mention over here, that there is something called as the cholelithiasis in weight loss also. So people who lose weight and who are very highly restricted in their diet, they are also having a high tendency to develop the gallstone. So sometimes very small sludge can just pass on to the pancreas and cause a pancreatitis, and may not be a very evident symptom. And the patient when complains that they are having the pain in abdomen or anything, many times we consider we just miss that, considering to be a side effect of the drug. So it's better to do amylase lipase every 3 months.
I have one more question because I mean, it's a known person had history of cholelithiasis, managed without surgery, but this was around 15 years back. The patient is now 115 kg, height is around 5'2", diabetic patient. OSA is that the female patient, she's on CPAP. age is 62.
Yep. I'm sorry, some calls are.
No problem. No problem, sir.
Yeah. Please. Yeah.
I mean, no history of any diabetic retinopathy. HbA1c is 8.6. Any risk of this patient going for a frank chole, cholecystitis if you put
So
on Ozempic or
no,
Mounjaro?
no. So the patient had cholelithiasis, right?
History of
Before
yeah, he was
15 years
on
back.
the drug UDC
So the answer is very clear. If a patient had a history of cholelithiasis and if the gallbladder is not removed,
15 years back. 15 years back.
it was removed.
No. It is not removed. But the issue was
So
15 years back.
So I got it. If there, even if there's a
Pre-menopause.
history of even if there's a history of cholelithiasis 15 years back and the gallbladder is intact and the cholecystectomy is not done, then that patient indeed is at the risk of developing gallstones, irrespective of whether we are putting the patient on medication on these medication or not. And in that group of patient, it is very important that we do the ultrasound before starting these, and we have to more vigilant in these people. Maybe we will do ultrasound more frequently than any other patient. These people are indeed at a higher risk of developing gallstones,
But no
irrespective.
contraindication, but high risk.
It's not a, so the history, and if the current ultrasound is not showing any gallstone, definitely it's not an absolute contraindication, but we have to be cautious.
So no fat infiltration of the pancreas and no current risk of gallstones. We can go ahead.
Absolutely. We can go ahead and we have to be just a bit more vigilant, but we have to go ahead. See, today we have to see more reason of giving, prescribing rather than denying. We have to be very calculatedly because we are fighting with a very big epidemic of obesity now.
So semaglutide versus tirzepatide, which is your call, sir. So
Both.
how will you segregate which patient to what to
Both.
give?
So a diabetic patient coming, definitely tirzepatide becomes my first choice. And for any non-diabetic overweight individual, that completely depends upon person to person. And it is something like nimesulide versus ibuprofen.
Any impact of GIP when you say that I'm going to choose diabeticity for Monjaro, I mean
So
for tirzepatide?
so anyone who is coming with diabetes with obesity, definitely my first choice would be tirzepatide, Monjaro, for sure.
Yeah. So what the role of this GIP in the patients? GIP substitution there, no, in like tirzepatide. Anything has to do with the diabeticity?
See,
Diabetes.
Monjaro has okay, tirzepatide has a better insulotropic effect compared to the semaglutide, and that's the where it has one edge when it comes to though it was Ozempic or it was semaglutide which got the first approval for the
Understood.
diabetes obesity.
And last one, Ozempic penis and Ozempic vulva. Want to hear from you, like, have you faced this in your practice?
No,
Lead this
not at
session.
all. I can tell you this, except for the thing what I read, what we see on the reels of
Hmm.
certain, some celebrity, quote
Yeah.
unquote. Otherwise, not at all. And even in that particular individual about whom it is being, said a lot. I will not take the name, and we should not. Whether it is because of Ozempic or because of something else, who knows? No, not at all. It's the other way
So
around.
3D patients, no Ozempic penis and no
40,
Ozempic vulva.
45, 40, 45-year women got pregnant.
Okay.
45-year accidental pregnancy. So that is what we are seeing. I'm not saying it's a treatment of fertility, but I'm saying accidental pregnancy. So what sort of the confidence and the thing and the self-image confidence people are getting?
Fantastic, sir. So, any other questions from the audience? Audience is there. Next speaker is almost finishing a procedure. Okay, just
So if there is no other question left, may I take your permission to leave?
please, sir. Thank you so much for joining, sir.
Thank you so very much, Natesh ji, and thanks a lot, the audience, and I hope I was in position to answer whatever the unanswered questions. And take very good care of yourself and everybody. Jai
Thank you so
Hind.
much, sir.
Bye
Excellent, sir.
bye.
Thank you so much. Thank you. Thank you. 2 minutes. Dr. Aram will be joining now. Please wait, he's joining.
Hi, Nadesh.
Hi, welcome, Dr.
I'm
Lama.
sorry. Sorry.
No problem.
Hi.
So,
Is it okay?
yeah. Thanks for joining amidst a busy schedule. I know that. So we're waiting to
Sorry.
hear from you.
Yeah.
Can you just switch on a light if it is possible in the car?
Yeah. One second. One second. Is it okay now,
Okay, that's
Nadesh?
okay. Please continue. Please continue your experience with Monjaro. You are endocrine surgeon.
Hi. Sorry. So
Please continue.
yeah. Sorry that I'm a little bit late. Sorry, there was some problem with the connection access. So anyway, Nadesh, thanking you for inviting me for this. It's wonderful to share my experience as a patient as such. I think it's a first time experience for me as a patient. So first, I will tell you like why did I started this journey. Thing is that I was overweight since childhood. So my BMI was always high, and I have family history of diabetes. I have family history of hypertension. My father underwent coronary artery bypass grafting in 2014, and my age is 42 right now, and my weight was around 137 kg. I was on antihypertensive since last 3 years, and I have a hectic work schedule also. Like every day, I started morning by 6. I finish my work by almost this time. This is my working schedule, and I had one episode of IVDP, I mean intravertebral disc prolapse, and I was bedridden for almost 6 months. And my spine doctor as well advised me to do weight loss. So all these things were there in my background, and I was worried like maybe I may be having diabetes in another 1 or 2 years, and backache. I have hypertension also. Then definitely I was worried about uh, coronary artery disease and CVA in future also. These all things were like really important for me. So what I thought is like, now I will do something. Otherwise, I may get into trouble in coming 5 or 6 years, maybe 10 years. This is why I thought I will think about going for a Monjaro. So I am basically a consultant endocrine and breast surgeon working in Southern Kerala, more in Trivandrum and Kollam. So I have my endocrine colleagues also. So I consulted them also, like how, because there were so many uh, talks all around, like regarding complications and all those things. So I decided, but go ahead, because when I was reading about the complications, going through the articles, it was not that significant those days. And main thing I was worried is gastritis, pancreatitis, and the visual issues. So I started with a smaller dosage and stepped up slowly. It's almost 5 months now, and now I'm taking 10 mg weekly dosages. So far, I experienced gastritis once or twice. That was like in the initial period, but I'm not on any um, pantoprazole or any PPI right now. I'm able to manage without PPI. And regarding um, my physique, weight loss was like initially suddenly almost in, even when I was taking 5 mg only, suddenly I lost almost 10 kgs over 2 months. Then it was slightly slow. Initially, I was not combining it with my workout and all those things. But since last 1 month, I started workout also, because little bit of sagging is there, and I think I'm losing little bit muscle bulk. So I'm doing regular workout, at least 5 days a week. I'm doing 1 hour workout daily, and a little bit of weight management also, weight also I'm doing. So far, if you ask me the satisfaction level, I had 2 episodes of loose stools during this 5 months journey, and that was like more of a security diarrhea, no fever, nothing associated. And because twice I had a binge eating due to some party or something like that at the end of the week or something like that. So that was the only difficult episodes. That diarrhea lasted for 2 days. The frequency was around 7 to 10 episodes over 24 hours. Otherwise, so far journey was quite good, and I lost almost 21 kg till today. 21 kg. So I was 137. Right now I'm 16.5 kg. Back pain reduced by around 80%. And so far feeling good. Only problem is like I had to change my wardrobe. So because I think lost so much of weight by now. I'm planning to continue this. If you ask me like how long I'm planning to continue, I kept my target weight as around 90, between 90 and 100 kg, and I'll be combining it with workout also. Once I consolidate it, later I'll be keeping in a lower dosage. That's what I'm planning right now.
Yeah. So, Armal, like, what was your starting weight and your height, BMI? Can you please tell us?
Initially, my weight was 137 kg. My height is 177 centimeter. So BMI is over 30, and as I told you, comorbidities are and as well IVDP as well. And moreover, I had OSA, severe OSA, obstructive sleep apnea. Nowadays, like that is gone. Night, as well, my wife is telling, no snoring, and daytime sleepiness, tiredness reduced drastically, almost 80 to 90% reduction is there.
Being a surgeon, how will you weigh for people like a bariatric surgery versus these injections?
See, even though I myself is an endocrine surgeon, surgeries have its own pros and cons. First of all, definitely, most of the things are not reversible after surgery. If you're going for a restrictive surgery or a restrictive plus malabsorptive surgery, it's a one do procedure. So definitely, surgery has its own complications. It might be less, but there is always a possibility of a complication. So I was a bit reluctant on a surgery as such. And even medication, I was initially a little bit worried about the complications, but I was doing thorough research before that. So far it's going really good. And more than that, if definitely now after Monjaro, one thing is their weight reduced and my eating habit changed basically. And I was coming across some mood issues articles, but so far my mood is in a really good shape. So far, it's a good option. Like, first of all, definitely you have to think about diet, exercise, and all. I was a person like I was not able to reduce the diet and exercise because of my schedule, maybe lack of motivation in diet and all those things, craving and all. So far, with the Monjaro, it came down drastically. It's a really good experience, Nadesh.
You didn't choose a gastric balloon.
No, so because gastric balloon as such, I might feel full. Definitely, that also one invasive procedure as well. So I preferred a pharmacological therapy before that. And
Is that
regarding, if you go through the research also in OSA, in obesity, IVDP, all those things, Monjaro is proven to be more effective as such. So I chose that option because of that.
any advantage of combining these two things, balloon and the injections?
So far, I didn't try for balloon. I
No.
didn't manage any balloon patients as such. I seen bariatric patients. So if you think about restrictive surgeries, definitely like initial weight loss will be the 20 kg, 10 to 20 kg in restrictive surgeries, but definitely it's a surgery. But compared with the Monjaro, in personal experience and in few of my patients, everyone behaved a little bit different, right? For me, 2.5 mg was a bit euphoric only, not that difference. From 5 mg onwards, I started getting the difference. And a few people, like one of my colleague, those who tried 2.5 mg had she was really intolerable to 2.5 mg. But most of the people are like 80 to 90% people won't have much trouble. But this is all depending on what much receptors you having that you can't predict as such. So definitely you have to start it in a smaller dose, slowly scale up, and there may be few people they might have intolerance, and few people will have really good tolerance also. One of my friend, he's taking 5 mg, not that much good. Like he lost 3 4 kg so far, but it's interpersonal variations are there. So we have to choose it wisely. That's it.
Any improvement in your any hormones, like where you measure anything with it, because you're endocrine surgeon?
Uh,
Out of curiosity, I'm asking you.
No, I'm actually I had a normal thyroid function test. All the investigations were normal. My
Okay.
lipotrophs also were normal. If you ask me specifically, my problem was hypertension, obesity, IVDP, and maybe pre-diabetic.
You
That's
are
it.
like your hypertension is much control now. It's better now. Hypertension.
Hypertension, so
Any advantage?
I am still on medication. No, I didn't
Okay.
actually stop my drugs. I'm still on drugs, so I can't
Okay.
comment about it, right?
Okay. Okay. So thank you, Dr. Aramal, for sharing experiences. If any of the audience which you want to ask him, please unmute and ask. Else we close the session. Okay. Thank you, Dr. Aramal. Thanks a lot for sharing your time amidst busy schedule. It's wonderful to get the experience from the patient as well as the doctor himself, where you'll be able to assess yourself and you explain in a very
Thank,
systematic way. Thank you so much. Thanks a lot.
okay, Nadesh.
Thank you. Thank you. Bye.
Thank you. Sorry for a slight delay. Okay, good night. Bye.
No problem. Thanks a lot. We understood that. Yes. So thank you everyone once again joining for the sharp session. And we'll be meeting you in the upcoming sessions and we'll be informing you as well. Thank you. Good night. Take care.